Thank you. Yes, this is a good exercise in modulating your presentation moment by moment based on all the input you're getting throughout the day, because this is great. So I'm going to take a different approach than I was going to in the morning and focus as we go a little bit more on the translational clinical trial piece, which is really where I kind of come at it from. So I'm trained first as a clinician and then in research, and so my interest is in kind of that interface of really getting these brilliant basic science things into the clinic. And my background clinically, I'm trained as an internist and psychiatrist, and then I had some research training in PNI. And so I've followed this work for a long time, and it's really exciting to have the opportunity to work on translating that. So as has been mentioned, there are multiple cancer models for this type of thing, and I focus in, as Erin did an excellent introduction this morning, focus on the stem cell transplant environment. And I got interested in this many years ago, and also realizing that there wasn't a lot of data in this area. So training as a clinician and seeing these patients as an internist and psychiatrist, many of these things became very apparent. So just to introduce why this is a little bit different than some of the breast cancer model, if you take and kind of overlay the PNI model on some of these factors that we're interested in, transplant patients are subject to very unique social and physical stressors. So they're necessarily facing a life-threatening illness, and then they're subject to prolonged periods of isolation. And with that, these patients have one of the more highly compromised immune systems of really any of the patients that we see, save for potentially HIV or AIDS population. So you kind of have the setup there. And then finally, you have the hard wiring of the central nervous system innervating the bone marrow, so you have the direct highway for these connections and processes to occur. So it's really kind of an ideal disease setting. And then I should say, in the model of the perioperative period, which is brilliant, we have a transplant that occurs on day 0. So it's not a surgery. It's actually very, if anyone's ever seen it, it's super anticlimactic, because patients sit there and it looks like they're just getting IV fluids, but they're getting their whole transplant. So you've seen these pictures now a lot throughout the day, but just to give you an idea, again, this is the structure for which we're basing these on. So the sympathetic nervous system and the beta-adrenergic signaling. So interestingly, there's a good amount of research in the retrospective epidemiologic trials in cancer, and I don't think we've covered this quite as much today, but there's really quite a bit of data in different malignancies. So you see breast, lung cancer, melanoma, whereby just observing that individuals who have those cancers have significantly less progression when they're also on a beta blocker. And that tends to be, and there's been talk about selective and non-selective beta blockers, that tends to be for the non-selective, so it seems to be more beta-2 stimulated, but this does occur sometimes with selective as well. And these differences are on the order of 20 to 30%, so it's not small. I mean, we're seeing very significant differences in progression. Again, you've seen these lovely pictures from Erica and showing from Don of the mouse models of this. So again, when you can experimentally manipulate in the basic science setting the mice and administer beta blockers, you mitigate the adverse effects of cancer progression due to stress. So that was in breast cancer. Don has shown this, as he told you about elegantly, more elegantly than I will, how this also occurs in the hematologic malignancies. So we do see evidence for that to extrapolate this, some of this data to the liquid tumors, as we call them. So there's indication, and this is one of the preclinical trials in myeloma, multiple myeloma, which Erin gave an excellent introduction to this morning, but propranolol in vitro does have effects in promoting apoptosis and anti-proliferation. And based on this preclinical data, there was a nice retrospective study out of Mayo. This is actually from an abstract at ASH. I haven't seen it published. I'm hoping they do. If not, I may email the senior author and ask them to publish it. This was about 130 in each, collectively in each group, between the control group and then 130 divided propranolol versus any beta blocker. And we do see significant difference in disease-free survival or disease-specific survival as well as overall survival in these multiple myeloma patients. So kind of switching gears to some of the work we have done, and thank you, Erin, for introducing the CTRA profile this morning, which is, again, the 53 composite gene scores and work we've done with Steve Cole, where you have inflammation, interferon response, and antibody response. And that's a gene expression profile that's conserved in many groups exposed to chronic stress. So what we had done, and this was through one of our large database, the Center for International Blood and Marrow Transplant Research, and they collect all observational data on autologous and allogeneic transplants worldwide. So there's actually mandatory reporting for U.S. allogeneic transplants. So we kind of took advantage of that opportunity. They always mostly provide a pre-transplant specimen, and then there's a lot of data about these individuals. So we looked at whether socioeconomic status is kind of a proxy for chronic stress would be associated with this gene expression profile, which has been in other populations, but again, we're dealing with a very medically ill group. So it's just prior to transplant, but after a lot of chemotherapy and other treatments for their malignancies. And this was in an allogeneic group transplanted for acute myelogenous leukemia, and they were in their first complete remission. So they were fairly homogeneous. It was 78 individuals of high versus low SES. And so what we saw was that, yes, the CTRA pattern was significantly different between those two groups. So kind of demonstrating this proof in this population. And that was corroborated by a lot of the other pathways that you've been hearing about and people that work with Steve, that the transcription factors that are mediated by the beta-adrenergic pathway were kind of up and down regulated as one would expect, confirming that. So in taking this information, because we had the information from this database on long-term survival and long-term follow-up, we looked at whether the CTRA profile itself was predictive of these outcomes, and indeed it was. So it was significantly predictive of relapse of their AML as well as leukemia-free survival. And again, these differences are on the order of about 20%. So again, that's a significant, a clinically meaningful difference. I should say these were univariate analyses. This wasn't what we were initially intending to do, and actually the samples just shipped to do an extended study looking at this in a group that's large enough that we can do multivariate modeling. But we did look at demographic differences between the two groups, and there was nothing that demographic and medical, there was nothing that readily explained this. So based on this data, in this article, there was interesting invited commentary, which it turns out you don't find out about that. You just Google your article and you end up seeing that somebody cited it. But these were two transplanters that, and we did posit that beta blockers could be useful in the article, but they picked up on that, which was nice, and kind of emphasized that again, that they see this as a potential adjunct, to individuals, again, who that is, and that the CTRA profile could be something that is monitored as a treatment response biomarker or even prognosticator in transplant. So there enters the current trial, and we're still in the process of enrolling individuals, and so I don't have the final data like Shamgar presented you with, so I'm going to focus on our first aim, really, and our first objective, which was the feasibility component. And again, kind of focusing, it's a lot more complicated, and I may probably preaching to the choir to many of you, but it's complicated to run a clinical trial, and how do we do this, with this particular, beta blocking interest in this population that's rather ill. So I'll be talking about that. So the primary objectives of this study were really feasibility, so whether we could get people enrolled, and then whether they tolerated the drug, because again, we're dealing with a very complex medically ill group. So they had a lot of things going into this, having myeloma. And then whether this beta blocker administration would alter the CTRA pattern, and that's the data that will be forthcoming. And secondarily, we will be looking at whether SES, depression, anxiety kind of modulate the response to that. And then finally, we will follow these patients out for some clinical outcomes. Again, not powered to do that, but actually the transplanters that I work with actually pushed that, and they wanted to see. So after they kind of argue, well, you're not powered to do anything, then they say, well, let's look at clinical outcomes, because I think, what if? So, and then we can get some effect sizes potentially. And I should say that why we decided myeloma and autologous, because if you notice, the prior data in CTRA was on allogeneics. that population is that much sicker and has that many more complicating factors. But for a pilot study, we really wanted to focus on autologous, since it's a little less complicating and there's less medications to suppress a new immune system. And then myeloma is not only for the factors that Erin discussed this morning, but it's the #1 indication for autologous transplant. So that in part is why is due to access and feasibility of enrolling in a meaningful way for a trial like this. So our eligible patients, we more or less wanted to be able to include everybody that was going for transplant for myeloma. So that's some of the inclusion criteria. We were excluding people, obviously, on beta blockers or people that had not tolerated or had contraindications to beta blockers, as well as those who had a prior autologous transplant. And those are kind of some of the biggest things, and I'll talk about that more. Oops, in that top. So our original sample size to recruit was 40. We have modulated that with the input, through the network and Leidos over time, and based on our ongoing enrollment processes, that we've modulated it to about 25, and we believe we can still do that feasibly and maintain scientific integrity and answer our study questions. So we are now starting patients on propranolol at day -7. They're taking 20 milligrams twice daily. We are escalating that dose to 40 milligrams twice daily after a week as tolerated. And we are assessing them weekly for blood pressure and heart rate, as well as I'll show you some other screens. So at the end, we are continuing patients on this for 28 days post-transplant. So day 0 is like our surgical day, really. So we're starting a week before, 28 days after. And the rationale for that is based on that being kind of the period of highest distress and anxiety in this particular group. And then it actually drops off quite a bit after day 30, more or less. And also doing this with a transplant process, you have to really align with the clinical assessment time points. And I'll talk about logistics and being a difficult thing that one has to work with when considering these. So this is just our clinical assessment time points. There's very strict toxicity monitoring that occurs, and there's protocols for that within the transplant group, which we've been adhering to, because you necessarily, oftentimes, you get neutropenic. So that can't be an adverse response, or you get hypotensive at times, and so there's actually kind of modulated guidelines for following that. And so we are getting blood at baseline, so prior to any propranolol administration, and then right prior to transplant, and then at day +28. And we will be looking at gene expression at those time points. So this is what we have so far, and I'll spend some time on this to wrap things up. We have started screening really in October, I believe, or maybe a little earlier than October. And we actually went through screening 28 people initially, and nobody enrolled. So as a PI of the experience, you kind of panic. And when we did kind of a postmortem then and looked at what the variables were, and it turns out the logistics and the process of the bone marrow transplant setting were getting in the way, because we're a tertiary care referral center. We have one of the leading transplanters in myeloma at our institution. We get people from all over. And so and there are actually all these rules with then shipping drugs, even though it's propranolol and it seems simple and inexpensive and safe and old, they actually have to adhere to most all of the same things as you would with any experimental chemotherapy agent even. So you can't ship across state lines, and you can't ship here, and you can't. So it was more complicated than we thought to kind of get started. We had initially wanted to start propranolol administration at day -21 to give a really nice run-in period and somewhat based on the mouse data. And so we ended up amending that to -7, and we got a lot of people right away because we were able to logistically. So again, when you're doing these clinical trials with this stuff, we have to modulate very much to what the natural treatment setting is for the malignancy that we're studying. So out of the patients screened, and it's interesting to hear Shamgar and Erica's input too, and Julie's about accrual rates, because we've been ineligible. Over half have been ineligible, and you can see this is predominantly because of beta blocker therapy. So we have an older population, as Erin told you, their myeloma is more common, over 55. So many are already on beta blockers, so they're excluded, and then many had prior auto transplant. So I like the idea of another intervention that you can offer the people that can't go on, at least your trial intervention. So those were the big ones, and then of the people eligible, we've had a high percentage, of 70% were unable to be enrolled. And this is less than I think our goal was about 55 to 70% that we would be able to enroll of who were eligible. So this is less than that. And patient refusal is a big one. So again, we're really informing the aims of just how you run these trials and the feasibility aims and what your obstacles are. Now this, we could have discussion about, why that is, and different people, clinical research coordinators, oncologists, myself, various people are talking to patients, but, and how you sell these trials and how it's pitched, and is it a treatment trial? Is it an adjunct treatment trial? Is it do you bring up stress? Do you bring up the brain? It's interesting. I've learned a lot, and I'm happy to talk more about that without taking up time now. And then competing oncology trials. When we opened this trial, there were no competing trials, but because of the rapidly changing landscape in oncology, there are 2 or 3 new drugs and new trials that came on since we started. And so I think once we fixed some of the logistics initially, this trial was the #1 accruing trial in our cancer center in Q4 of 2016, and then a new drug came out and it plummeted. So we're constantly kind of navigating that, because it's not, and I've had that feedback from people that, well, they don't view this as kind of tantalizing as a brand new, immune modulator type medication. So I'm interested in, ongoing feedback and dialogue with this group in particular about how we address that in the oncology settings. I know I continue to think about that. And then logistics I mentioned, and we have done everything we can to address that. So we have 17 enrolled, actually 18, because there was another one this week, and I couldn't be as up-to-date as possible. But so they're accruing by the minute, and we're always making changes. We have had a fairly, actually a better than estimated retention rate. So we were hoping to retain about 65 to 70%. Again, these individuals necessarily oftentimes will get hypotensive afterwards, and we've been able to keep, most people have stayed on. I think there was a one that came off because of symptomatic hypotension, although it was not deemed that was necessarily secondary to the propranolol. She just had that. And then only one person was unable to be escalated in dose, and one other person had to be given propranolol for medical reasons in the control group. But that is kind of an overview of what our patients are doing thus far, and as soon as we hit our goal, we will have additional information about gene expression. So I'd just like to acknowledge everybody who's helped in the conceptualization of this and the implementation, and very much to the network, both for the support and just the logistics of doing the trial, but really for facilitating meetings and conversation like this. I really look forward to that as an ongoing resource that we now all have. And I've already laid out to you some of the things that I think I'm interested in ideas about. So yes, thank you all for your attendance and interest, and let me know if you have questions.